the whole healthcare industry is going to change dramatically in the next couple of years.
To chronic disease management and the preventative aspect of care.
AI can now understand the key clinical concepts of what's being verbalized in healthcare.
Welcome to Cherry Live. I'm Dr. Jordan Valrath, physician, entrepreneur, and Chief Medical Officer for Cherry Health. We're talking about Canadian healthcare. Join us as we speak to innovators, industry leaders, and people working to drive the health system forward. Chris McGuire. He's the General Manager of Records Access Services Canada, also known as RASCI, with over 15 years of consulting, operations, and management experience. RASCI is an industry leader here in Canada in records access services, especially relevant to physicians and healthcare providers, just with the duties and obligations around their patient and health data. So Chris, thanks so much for joining us.
Oh, thanks for having me today, Dr. Valrath. It's great to speak with you and meet with you, and it's great to have a conversation about an increasingly important topic in healthcare.
Yeah, so we were just kind of chatting about things before actually getting going on the podcast, and this seems like the kind of thing, to give a healthcare analogy, the green sheet and the goals of care designation and that advanced care planning. When we're dealing with patients, these are all like really important things to have sorted out ahead of time. And then if you don't, when urgency strikes or emergencies happen, right now, suddenly you're caught lacking, and it just is way more stressful than it needs to be. And so same thing applies when it comes to actual patient records data. Yeah,
absolutely. And we see that sentiment very often. We'll speak with physicians as they're nearing the end of their practice, whether they're retiring or just transitioning into a new area. Once we outline all of the requirements that goes into the closure, they often get overwhelmed as well, because they realize that, they didn't necessarily have a good strategy for this part of their career. And, we present them with a couple different options. And when they see what is required, if they were to do it themselves, not only does it seem overwhelming, it also, trying to juggle the closing of the practice. So, making sure all your notices to patients are properly done, making sure you forwarded referrals and contacted pharmacy, all of that has to be managed well. You're also getting inundated with calls from patients, asking now about, what's going on with my medical records, what's going on with your practice, what should I do? And that's where, increasingly commonly, we're stepping in to provide a much needed service to, alleviate that burden from physicians so that they can focus on still providing the best care that they can while they're closing their practice, while also focusing on, the day to day and not worried about, the now inundation of requests and calls from their patients.
So when it comes to the actual records keeping itself, what's involved? What does that actually entail on your guys' end? I've only really experienced it from like the locum physician standpoint, where several years later, then an insurance company has hunted me down. They saw that there was a encounter with a patient, and then I'll try and figure out which clinic this was at. And then I say, I have no access to these patient records anymore. You'll have to look at the clinic themselves. So I'm like completely removed from the actual duties and obligations side of things as per the record keeper. I don't know how this actually works. What is record keeping then? What do you guys actually do with the records?
Yeah. So, it sounds, I don't know if there's an exciting spin you can put on it, but, at its core, it is a record storage and management. So if it's physical charts from a physician's office, they're stored, labeled. We put them into inventories that we can index them quickly, so that, if we had a physician that closed 6 years ago, and we get a request from, an insurance company or a law firm, we can quickly locate that file in its proper place in our secure storage facility, pull it, prep it, and prepare it for transferring. So, that's from a physical component. And then, now as physicians have transitioned to EMR, it's the same, where, the files need to be kept. We have digital backups that have to be stored in compliant storage facilities or devices. We usually have to create backups so that, if a physical damage occurs to one, we have a backup of the backup, right? So, it's one of those things where you try to plan for all different scenarios, but essentially you're trying to do your best to maintain that original copy in its original quality from the day you receive it until the day it's eligible to be destroyed. So you can imagine some of these physical charts that have been around for 20 years. They need to be maintained properly so that they are still legible in 7 or 8 years. Because all physicians, especially physicians that have had a family practice for 30, 40 years, they sometimes, they won't necessarily trim down their files as they can. So we'll get a patient's file that is its entire lifespan, and, pages that are 30 years old, if they're not stored properly, they become in they aren't legible after a certain amount of time. So like I said, our goal is always to maximize the quality of the record so that during the retention timeline, it can be reproduced on demand for a patient or a requesting agent.
How do you actually en masse handle that type of volume of paper? Like, I'm picturing just a giant warehouse. Does the Dewey Decimal System still apply here?
Yeah, that's pretty much it. It's a large secure storage facility, and we're fortunate because we're starting to hit that transition where there are more physicians that are on EMRs. So we're seeing even blended systems where physicians have converted most of their physical records to EMR, and that helps obviously with the volume of paper. But I think it was you had a conversation with Dr. Sharma where you mentioned 40% of physicians in New Brunswick are still on paper charts. And I am dealing with, that situation where, a lot of them, it's entirely physical charts. There's not even a computer in the office. So, these files are coming to us in their very original form. So, so, what's convenient is there are guidelines in terms of if you digitize a record and you can attest to the quality that it's consistent with the original, then you can destroy the hard copy after it passes quality checks. So, what is convenient is, if a physician closes and they have a lot of physical charts, as patients request copies of their records, we're creating digital copies, which allows us to reduce the volume of paper on hand. So like I said, there's a bit of a balance between long-term storage and short-term storage. And it's, at its core, it's just an inventory management system. And you just do your best to index and maintain the quality. And like I said, there's certain files and charts where, I mentioned it to you beforehand where, WSIB records, for instance, in Ontario, some of them need to be kept for over 40 years. So, some physicians and specialists, yeah, exactly. So some physicians and specialists, they have an option. They can either pay, to have those records put into long-term storage and just maintained, or, we can actually provide digitization services, which is significantly cheaper in the long term, from just paying for generic storage. So this way it creates a digital copy for both the physician and their storage requirements, and they don't have to worry about the long-term ramifications of the storage.
What possible context would you need to pull out a 40-year-old file?
So like I said, in Ontario, with WSIB, if it's workplace injuries, claims against a company, those are the files that WSIB Ontario has outlined need to be held for that period of time. So, I don't set the guidelines because I know, like I said, some of them are pretty stringent. So we just do our best to support the physicians who are, adhering to these guidelines once they're going into retirement. Because again, if you have a physician who's retiring in his late 60s or early 70s, and he's got a file that's supposed to be stored for 40 years, the math doesn't really add up for how he's going to be able, or how he or she's going to be able to manage that record for 40 years. So, it's either the physician has a plan in place to continually pass on these files, which comes with a whole broader set of issues for managing that file, or he assigns it to a custodian like ourselves to manage it for that timeline.
That's crazy. Okay, well, hopefully that's not necessary too often, but I guess the rules is the rules.
Exactly. Yeah. Like I said, the recalling a file like that isn't as common as you would think, but you still have to be compliant with those requirements. So, like I said, maybe they'll change them in the future, or there'll be a different filing system that allows us to make it a more convenient process. But it's what we currently deal with as in place right now.
How do you actually set up a payment and I'm picturing, if you get yourself cryogenically frozen after you're dead, you have a giant trust, and the interest in that account funds your liquid nitrogen refills. Is that how this has to operate as well?
So that's it's interesting, the storage contracts, they can be complicated in the sense that you're looking at long-term storage, and we try to make it as cost effective as possible for physicians. So we do tiered storage and we reduce the pricing annually as we can, as files come up for destruction. But if you're a family physician, there's actually a lot of ways where the price can be reduced to potentially free services for a family physician, especially if we plan well in advance with the family physician. And then it's specialists who typically their files have already been passed off to a family physician, so they're just paying you typically for the storage of their records, because it's very uncommon for a specialist to have their files recalled. So their objective is just to have it securely stored, and they have the peace of mind that their records are going to be compliant with their requirements. Whereas family physicians, again, because there's usually a lot of requirements and requests for patients requesting their files. If we work with them early enough, we can usually create a payment system where the physician actually has no cost for storing their files for 10 years, which is obviously ideal for them. And then they have the peace of mind of, again, not having to answer a phone call in 5 years from a patient looking for a copy of their medical record.
Yeah, it's hard to argue with the price of zero, free for 10 years. That sounds nice.
Yeah, exactly. And the key to that, and I mentioned this to you while we were chatting, is trying to have the foresight to plan for your closure. It's your last podcast on physician wellness with Dr. Joanne Lajoie, highlighted a very common theme these days with physician burnout. There's a lot of people leaving the practice, and they're not leaving the practice by choice. They're being forced out of the practice because of health reasons. And, they're stuck in awkward positions because they either physically can't deal with the transition and record storage requirement. So it's the admin staff or family members that are required to deal with this. And when that happens, the cost can increase because there's less planning and there's more overhead just to get the whole process started. So, I always say, even if you're not retiring in 6 months or 10 months from now, if you have the ability to plan a year out minimum, that is the best case scenario, because, people often think about practice closure as, I'm closing up my practice, I'm going to send my patient notices, do this and that. But, these are small businesses for a lot of physicians. So, there's legal ramifications, financial ramifications. There's, whether you're leasing your office or you own your office, all the offices, there's such a long checklist that needs to be considered. And it's unfortunate how common it seems to be. It's coming that doctors are calling us at the last possible minute because they've been holding out hope that someone might step in and take over their practice, or like I said, they've just hit the physical end and they can't continue practicing, and they need support immediately. So, for us, even when we don't work directly with a doctor, anytime we speak with doctors, we are just trying to raise awareness, because whether you engage with us now, in 3 years from now, we just want it to be something that it's more top of mind. They're more aware of what they should be doing, and it's not something that sneaks up on them at the very end.
And so, backing up a little bit here, what are the actual requirements, the obligations that the physician, the chiropractor, you name it? And then I guess, does it differ depending on your profession or what association you're regulated by, or is it all government mandated? This is health data. What are we actually uphold to do with our patient records?
So yeah, when we look at the record retention requirements in different provinces, it's usually the CMPA does a good job of outlining the specific needs in each province, and each college has guidelines and recommendations. So the CMPA has a listed retention timeline for physicians in Canada. So this is just a blanket physicians in Canada. So specialists, family practitioners, it's all applicable under this umbrella. So, but then by each province, there's variations on those requirements. So for instance, in Ontario, it's 10 years from 10 years from the last visit, or it's 10 years after someone comes of age. So if you have a patient that's 1 year old, after they turn 18, then it's 10 years on top of that. In Alberta, it's 10 years from the last date of entry, or 2 years from when the patient reaches the age of majority, whichever one's longer, right? So, each province has its own variation, but, in essence, it's always a 10-year minimum is what we work with. And, typically for physicians too, we try to only bill for 10 years. So that, if a specialist comes to us and they have kind of a mix of pediatric files and adult files, we still only bill them for 10 years, because the complexity of then having to separate out a specific list for pediatric files and then bill on specific quantities of pediatric files becomes so complicated, and it creates a more of a hassle for the physician, that we just manage that on our side, and it's one of our ways to create a hassle-free solution. It's very convenient, neat package that we present to them, saying this is the 10-year storage requirements, this is how we're going to handle it. If you have pediatric files there, we're still going to meet all the storage requirements, but from a billing and cost perspective, we're just going to focus on 10 years.
And then earlier when we were talking about the paper records, you mentioned that sometimes the clinics will trim the records as you go. Is it what lets you actually trim parts of a record out? Is that time, like it's just a chronological thing, or is there anything else that you would be thinning your records based on?
Yeah, so that's up to each physician, obviously. So the physician can thin out their own records if they deem previous information no longer applicable to the treatment or the profile. So that's an individual call by each physician. But when I speak to some physicians who actively manage their records like this, they use the 10-year cycle. So if they have a patient that they've had for more than 10 years, they kind of look at it as 10-year cycles. So if they have information in that chart that's more than 10 years old, if they deem it's not applicable anymore, then they'll trim that from the file. Because you can imagine, some of the older physicians who've been practicing for 30 years and they've had patients, they follow the old cradle to grave mindset of, treating patients. You'll have an entire life's history of some of these patients. So, like I said, it's for their benefit usually to manage the size of the charts. And then also there are guidelines on providing chart summaries to patients when you are closing. So, some physicians who have the time and have planned well in advance, they will actually prepare abbreviated charts for their patients. So you might have a 200-page chart that the physician has reduced to about 40 pages or 30 pages of the most important information that they know the patient needs for continuity of care and bringing it to the next physician. So like I said, it's usually up to the physician and their discretion. And it's not as common for the thinning out to occur because physicians, they seem to like to have all the information at all times. But the ones that are diligent with it do a good job of maintaining the most applicable materials.
And so it's more of like a space saving, keeping things tidy. Is there much of an argument to be made to like be thinning out your digital records if you're using an EMR system and you've had patients on there for 20 years?
You know what, there's less of an argument because the footprint is much smaller. And as what we see as common is, a physician who's transitioned, especially in Ontario, the transition is happening. It's been happening quite frequently over the last several years. you'll see the EMR only has 5 years of information in the sense that it's indexed, it's inputted, and it's all up to date. But then it'll have 20 years of information that's just an attached PDF. So the PDF is just there for reference, but you really only have a 5-year chart in essence. So it's one of those things where the physician, they find it's twofold, where they can get rid of the physical footprint of the chart, but they now feel better that they can keep the whole chart attached to the patient history. So it's a bit of a compromise as physicians are transitioning. But like I said, in terms of the capacity and footprint, there's no real need to trim digital charts unless there's just a preference of the physician. But at that point, there's not as much of a need.
And then back to the requirements, the obligation side of things. So we talked a little bit about just the time period that you have to keep these charts around for. What other obligations are you beholden to in terms of like patient trying to access it, or if the police trying to access it, or an insurance company, or the WCB occupation? What's the actual rules around that?
Yeah, so it's a good question because one of the conversations I'll have with physicians, at times they'll present an idea to me on how they're going to manage their own records in their retirement, and so we go through a bit of a an example of what they might encounter in 3 months, in 1 year, 3 years, so on and so forth, and whether or not the physician is equipped to respond to those requests. So it's one thing for them to think, okay, I'm retiring, I'm closing my practice, I'm just going to, let's say it's an EMR, I'm just going to create a digital backup of all my records so that I can transfer them. So, then you have to start asking all the questions of, are you storing these files in a, secure, compliant platform, either online or offline, depending on what you're using? Do you have appropriate backups? Do you have a file transfer system that you can send encrypted files securely to patients when they request it? If a patient, if they want to call you, what number are they calling? Are they calling your home phone at 10 p.m. at night? Because we get calls 24/7, with different time zones, different requirements. So we're always getting calls, day and night. And then if you do get a request, if you're on vacation, let's say you're fortunate enough to be retired and vacationing somewhere overseas, you have a requirement to respond in a certain amount of time. So it's one of those things where you always have to be accessible. You always have to be able to respond within 30 days or less and provide a copy, or at least provide support for why a copy hasn't been produced yet. So there's all these considerations, and that's just for the digital storage, right? That's what I would call the easier side of things. If you're a physician with physical charts, there's a whole other slew of considerations with, where are you storing that? Is it in a climate controlled area where, if you put it in your basement, which we've seen before, what happens if there's a flood and your records are, flooded, or a house fire? There's all these things that you're liable for as a physician that you need to consider. And then same thing, if you get a request and that means you now have to convert that chart into a digital chart. So do you have, a high quality scanner that can reproduce that chart in a manner that's acceptable from a quality perspective, right? So there's all of these considerations that they don't necessarily put a lot of thought into up front. So we have the conversation with them and we say, these are all the things that you will be required to do if you want to do this yourself. And are you, so as you go into retirement, is this what you want to be worried about in your retirement? Do you want to enjoy and have the peace of mind that everything's being handled? Or do you want to be on call again in your retirement at, a moment's notice? So it's again, it's every physician's individual choice, but once you lay it out and you kind of describe the scenarios that may arise, it becomes a much better case for them to use a custodian instead of trying to do it themselves.
Yeah, it sounds like that could turn into a nightmare real quick. Like the time periods that you described. I mean, I feel like your practice insurance, your CMPA coverage would have no longer been required by the time you get to, year 39, and then you get a flood in your basement and the record dissolves. Like, what?
Yeah, and we've had a call where physicians called us to their house, and we go in, and it was a flooded basement, and so then they're trying to pass on the files to us after they've been damaged by a flood. So, it's
There's a big soggy mess.
yeah, exactly. You can't quite have it both ways like that. So, and like I said, we've been focusing on retirements and physicians that have been practicing their whole life, but there is the other component where again, covered with your conversation with Dr. Sharma, is younger family physicians have a different mindset. They're not working the 5 or 6 days a week and seeing as many patients as possible like the previous generation, because they've been disincentivized to do that. So we are seeing more commonly younger physicians, they're spending time in an area and then they're relocating to a different province or a different practice area. And it's same with them, is they just want to be able to close up what they're doing and not have to kind of continually readdress requests and follow up. So even if they, in theory, have the capacity to try and manage it, they're trying to move to a different area. They're trying to focus on a new venture in their life, and they don't want this kind of keep coming back constantly. So that's another thing that's becoming increasingly common as well, is seeing younger physicians relocating and transitioning. So again, all the same things apply with the practice closures and retirements, but for these scenarios.
So let's assume we're going to be a good boy and get this sorted out ahead of time before disaster strikes or before retirement is, just around the horizon. What do we got to actually do to premeditate and have this all set up in a nice, orderly fashion?
Yeah, so we have a 12-month checklist that we provide to physicians, and what's nice about this checklist is, and this has happened before, is even if we go through the entire checklist and we get to we're nearing the closure date, we've had physicians who continue to say, what, I'm going to push this off 30 days, 60 days. And we're okay with that because we started the process early enough that we can accommodate those changes. So like I said, 12 months out is when we start with the physician and we build that plan. So we send them our checklist and we go through, for the first 6 months, it's a lot of administrative items and tasks that are really have less to do with the record management, but it's more about organizing them and their operations, so that the things that will creep up near the end they don't get caught off guard. So they're speaking to their financial advisors, they're speaking to the building owners, and they're speaking to, if they're part of a family health team. It's about again, the more prepared you are, the easier the transition is. So the checklist is really just to hold everybody accountable to a timeline and to items that will limit the distractions and roadblocks as we get closer to the patient side of things. So, once we get to the 90-day mark, that's when, at least 90 days before your closure, that's when patients should be receiving their notices. And then obviously once the notices go out as well, you get inundated with calls and requests. So, if we've gone through that checklist and we've managed everything else, then whether the physician wants to handle those calls or if they want to direct them to us, they're not trying to deal with the administrative cleanup at the same time. So again, every physician is a unique scenario. So that's why our checklist is comprehensive. Some of it's not applicable to every scenario. Some of it is entirely applicable. So that's why, I really enjoy working with the physicians, because every practice is unique. Every story is unique. These are all, it's very personal for the physician. So it's very important to me that we're there, we're listening, and we're trying to guide them through the process, because, this is a huge life moment, a moment in their life for these physicians, especially if they've been practicing their whole life, right? They've dedicated their life to caring for a community or a city that they're in. And so, trying to make it as seamless as possible so that they can focus on what matters to them and not worry about like I said, the administrative stuff is where we try to provide the most value to the physicians.
And then is there, you mentioned this is like in the months leading up to the practice closure. Is there utility in starting this conversation way early on? Like if I'm setting up my practice right now or joining a clinic or something like that, like should we be chatting with somebody about record storage, just in terms of getting our files, how to keep them, how to sort them, how to actually create them? Is that something that would be useful or not really?
Yeah. So, I mean, there are certain things, there are, guidelines on how records should be managed while you're practicing. Obviously, the college can frown upon poor record management practices by physicians, and we've seen that before. So, that is a consideration. We have worked with clinics in the past who have asked us to manage record requests from third parties. So if, for instance, certain clinics, they see a lot of patients, and they'll get a lot of requests from hospitals or insurers. So we've actually acted as an in-between, and we set up appropriate consent so that we can retrieve the file from their practice and then transfer it on their behalf. And it's also so that when you're actively practicing, you have to also be adhering to the requirements, privacy and security requirements when you're sending out records. So, if you don't have the training within your own practice on how to send and transfer records securely, you could be sending data incorrectly or using a system that doesn't meet the privacy requirements, right? So even, secretaries and admin staff need to be trained internally to ensure that you're going through the right checks and balances of what files are being transferred. So, like I said, that's one component on it, but the biggest thing for new physicians is just having a good records management system in place so that when it is time to come, you can pull it out. And it's even something which we've learned the hard way with some EMRs is some EMRs are not well equipped for the export of patient records. There's so many different EMR platforms out there. So, and like I said, a lot of physicians don't necessarily think of this when they sign up with an EMR, but you should be asking the EMR, what is the closure protocol? What is the extraction protocol? Some EMRs charge quite a bit of money for the doctor to extract the patient records. Some don't have the technical ability to actually export it in bulk. So we've actually gone in and exported patient records one by one for some physicians. Because it's the only way to maintain a quality copy of that record, because some EMRs will provide it in a bulk database, but it doesn't retain the organization and structure of the original chart. So, that's something that if we are working with a family physician ahead of time, we can actually do that for them at no cost. So if we have to export 1,000 patient records one by one, we're willing to do that for the physician if we have enough time and notice to be able to do that for them. So like I said, these are all considerations that, the one physician I just spoke with recently, they said they would never have chosen the EMR that they're with if they had known how difficult the closing process would have been. And there's a lot of issues that we're dealing with that specific platform. But again, it's one of those things that you don't think of it when you're signing up because you don't see the end when you're just starting, obviously.
Yeah, no doubt. That would catch you off guard.
Yes.
Is there a shared duty between the clinic owner or the manager of the clinic versus if you're just a contract physician who happens to be working there? Or is it, responsibility goes to the doctor no matter what?
Yeah, the responsibility is to the doctor no matter what. So, we've seen, commonly there'll be several doctors on a shared EMR. And it creates some issues, logistical issues with exporting just one doctor from that EMR. And it usually requires consents and notifications to all the other physicians so that everyone knows what's taking place, what's being extracted from the EMR. So yeah, even if you're only there temporarily, you still need to have something in place to extract your physical charts and keep them separate from the other physicians. So, which obviously with the rise of the family health teams, which is, something that's growing, it gets a little bit more blended and mixed. So, having, for instance, if you are joining a family health team, there should be something in place when you start, or when you're creating your EMR system, to show, a divide between charts, between whose chart belongs to who, so that if anything ever happens, you can easily extract your files and not get it mixed up with another physician.
Let's say we did not abide by these rules and the regulations and all these obligations. What's the fine? What's the penalty? What happens if you're actually in violation of any of these standards?
So it varies. You deal specifically with the IPC, the Privacy Commission. So again, it's not something I've had to find out about, thankfully. Our goal is exactly. So, again, that's probably something I can't speak to specifically, because the fines can range from warnings to notices against the company to monetary fines. So there is a broad range, and it depends on where you are not in compliance. So again, it's one of those things where if you're managing your records properly and you're following the appropriate security and privacy protocols, you shouldn't ever receive a notice from the Privacy Commission. So again, it's one of those things where in extreme cases for physicians, we've seen a college actually step in and assign a custodian of the records because they haven't managed them. So there wasn't necessarily a monetary penalty applied to the physician, but they were stripped of the management of their own records, and they had to go through disciplinary hearings and training before they could have their records back, right? So there's different interventions that can take place depending on who's out of compliance and what actually transpired. So again, it's a big umbrella, and it's just easier to be compliant than to not be compliant.
Okay, so let's be compliant then. How does the patient actually interface with those records later on? Doctors moved, they're on an Antarctic expedition, or they're deceased, or they're, how does the patient even get a hold of these records in whatever situation arises?
Yeah. So when a closure takes place, part of our checklist involves, giving the colleges appropriate notices, so that, when, even if a physician retires and a patient hasn't been there in 2 years, the custodian should be clearly listed on the physician's profile, either on the college website or a physician profile. So what we do is we provide templates to fill out so that we can upload them, send them to the college, and they can upload or update the physician's profile with our information, which says, what date the files were received. So that the patients know, they have our contact information, how to reach out to us. When a doctor retires, part of the notification process, or retires or closes for whatever reason, we send out mail notices, we call the patients, and if we have email address, we also email the patients. So, our objective is to notify all active patients, or at least, if we have enough information, any patient that's been to see that doctor within the last 5 years. So even if they're classified as inactive or derostered, if they've been to the clinic within the last 5 years, we try to include them. They're included in the notification system if the physician still has all the appropriate information for that patient. So, that's, 3 to 5 minimum points of contact. And we usually, at least a year or a year and a half after the closure, we send out another notification as well. So, we do our best to make sure that the patient is well informed. And then, like I said, the more notice you have with the physician and their closure, the better the communication is with the patients, because we do our own communication, and then we encourage communication to come directly from the physician, so that no active patient should be missed. And then it's obviously the inactive patients who you try to get a hold of, but if they haven't been to the physician in 5 years, sometimes their contact information might be out of date. So that's why posting all of our contact information on the college website for that physician is our last resort for trying to make sure we're accessible.
That makes sense. And then does it cost anything for the patients to get their records down the line? Like if a patient comes to the clinic and they want copies of all their stuff, there's sort of standards and guidelines for fees to charge. Does the patient need to pay you guys as well, or how do you actually deal with that transaction?
Yeah, and that's probably the biggest issue we deal with patients, and even me before I came on board with RASCI, the concept of owning your medical record is a lot of people don't understand that, where the physician owns that medical record. So as a patient, when your physician's practicing, you have a right to request access to view your medical record, but the physician cannot give you the physical copy of the medical record. So whether the file is with a custodian like ourselves, or if the file is still with the physician, in the physician still practicing, like you said, there are fees that are set out for the time and effort required to reproduce the document. So we try to adhere as closely as possible to the posted fee schedule that's online. And like I said, we've capped our fees and we offer as much of a discount as we can. And that's one of the things that we always express with physicians is we've capped our fees. So we're one of the most cost-effective solutions for patients, because, it's unfortunate for the patients, because they're in a bit of a lose-lose situation, right? They're losing their family physician after X amount of time. And they're also, for most of them, they're learning for the first time that they don't own their medical record. So like I said, when we speak to the physicians, we promise that we will cap and not raise our prices. We offer discounts, and we also, if someone doesn't have the ability to pay for a record, we don't withhold the record. We still provide a copy of the record, either at a discount or for free if the case is required. So, we understand that the patient is in the difficult position regardless. So we do everything we can to keep our costs as low as possible back to the patient.
Yeah, it makes sense. Okay. So in terms of when people need to get a hold of record services, so practice closure, you're moving, physicians no longer practicing or deceased, any other times where this needs to be something to be talked about?
So, for some individuals, digitization of records is also just another component that or service that we provide. So, a lot of physicians, will, if they take over a practice, which is becoming less common, if they have physical records that are taking up space, then, even if they're not closing for 5-10 years, they might want to just reduce the footprint at their office. So even digitizing records that are currently on hand is something that we do with them. And that's also a way for us to begin engaging with them well ahead of their closures, so that they can anticipate and keep it on their horizon for when it comes time. So that's one way. There are EMR transition services that we provide. So even if you're not closing, if you're transitioning from one EMR to another, if you're in a family health team and you need to extract records, like I said, so it's also common where now if you are on a shared EMR, you might set up your own profile and create a separate account. So there's a transition and migration process that we can support with. So there's a lot of different things that we try to help with. And like I said, right now, obviously, because of the transition from physical to EMR, we are seeing a lot of requests for digitization, so that physicians can reduce walls of charts that they have stored right now and convert them so that they can go into an EMR. Because we've seen some instances where physicians are just choosing to retire instead of transitioning to an EMR because they think the workload is so significant for that transition. So again, we even try to provide, there's a charts on demand service that we even provide. So if a physician's transitioning to an EMR, instead of looking at it as, I have 1,000 charts that all need to be digitized, we work with them so that we're kind of digitizing on demand, so that we can reduce the cost for the physician and digitize charts and provide them back to the physician as patients are coming in to see him or her. So it allows us to, again, reduce the upfront cost for a physician who's going through that transition, but still provide the digital copies at a high quality, and then also secure destruction and shredding, so that as we're doing it, we're removing the files for them.
Clean up all that space in the office,
Yeah.
I guess.
Exactly. Yeah.
What about for any of the dentists or dietitians listening right now? Does the same thing apply? Is that all patient health information as the privacy officer would define it?
Yeah. So, my comment is always we always check with the applicable college for their recommended guidelines, but they usually fall under the specialist category where, there's a good chance that no one will be seeking that file, but they have to adhere to their practices, storage and retention requirements. So, when we get a specialist, we meet with them specifically. We pull up their guidelines that is custom to them, and then we adhere. But, again, as a blanket statement, we always say you have to anticipate 10 years minimum, and then we assess the requirements forever. So, if you're a pediatric doctor or a specialist, we tell you from the get-go, let's just assume it's 28 years minimum. But you still, like I said, typically we still only bill for 10 years, but we will store your charts for at least 28 years. And then as we index it and go through the files, we understand, the patient breaks of how old they are, when the chart can be classified for destruction. So.
Okay, cool. All right. So I'm feeling a lot more well equipped to handle running practice.
Yeah, like I said, it's a unique industry. It's something that you don't really hear a lot about it, and then all of a sudden, it's right in your face because you need it, right? So it's one of those things where even me, I've learned a lot about this space, and hearing the stories from the physicians, it's been very rewarding to hear their stories, because you get to hear what they've gone through at their practice and how much it means to them to they spent their whole career with these people, and you get that sense of pride from the physician, and then also remorse that they're now having to close up shop. So it's a very fascinating dynamic. And like even some of the patients that call and request their records, you get some great stories and anecdotes about their experience with their physician. And they're often they are upset that they've lost their physician, but they share unique stories about it. So it's a very interesting dynamic, and I would say it's a service that's one of one. It's very unique, and it's something that I'm happy that we're providing the best service we can to both physicians and patients.
And if somebody's approaching a transition period in their career, where can they find you?
Yeah, so you can visit us online at RASCI.ca. So it's RASCI.ca. Or you can call our toll-free number, which is also on the website. Or you can just email us at info@rasci.ca. And typically we respond as soon as we can. And like I said, it's never too early. Even if you're just looking for information or steps, if you decide to work on your own or work with us, we just want to make sure you're well informed, so that, like I said, it's not only for the physician, but it's also for the patient's best interests. Because, also preparing the medical records is important, because, if a patient doesn't have a new family doctor lined up, for instance, having their medical record in a well-organized format, can help if they see a pharmacist, because pharmacies have expanded abilities now, and nurse practitioners have expanded, abilities for treatment and care. So, we always try to convey the message to the physicians and the patients that, having ongoing care, it doesn't, just because your physician's retiring or leaving doesn't mean your care has to end, and there's ways to continue that.
Awesome. Okay. Well, thank you so much, Chris, for joining and just sharing all that with me. I feel a lot smarter now than I was an hour ago.
I appreciate the time. And like I said, it's a conversation that probably doesn't come up as often as it should, but I think it's an important one to have.
Yeah. Again, another area where a little bit of foresight and planning goes a long way.
Absolutely.
Thank you.
All right. Take care.